Foreign bodies, Bezoars, and caustic ingestions. Patrick R. Fa, Mark Benson. 28 Gastrointestinal foreign bodies, GIFBs, are composed of food bolus impactions and intentionally and unintentionally ingested or inserted foreign objects. Bezoars are ingested materials, food or other materials, that accumulate in a normal or abnormal stomach. Caustic ingestions present following ingestion of acid or alkaline materials, which may result in acute and/or chronic injury to the esophagus and stomach. These topics are discussed in detail in this chapter. Gastrointestinal foreign bodies GIFBs are a common problem encountered by gastroenterologists. Most resolve without serious clinical sequelae. 1 Older studies have suggested that between 1,500 and 2,750 deaths occurred in the U.S. secondary to GIFBs. 2-4 More recent studies have suggested the mortality from GIFBs to be significantly lower, with no deaths reported in over 850 adults and only one death in some 2,200 children with reported GIFBs. 5-11 Regardless of imprecise morbidity and mortality rates, serious complications and deaths result from foreign body ingestions. 12-14 Because of their frequent occurrence and potential for negative consequences, it is important to understand which patients are at risk and know how to diagnose and treat GIFBs and deal with their complications. Epidemiology: GIFBs may result from unintentional or intentional ingestion. The most common patient group that unintentionally ingests foreign bodies is children, particularly those between ages 6 months and 3 years. Children account for 80% of true foreign body ingestions. 15 Children's natural oral curiosity leads to placing objects in their mouth and occasionally swallowing them. Coins are the most common objects swallowed by children, but other frequently swallowed objects include marbles, small toys, crayons, nails, and pins. 6, 10, 16, 17 Accidental ingestion due to loss of tactile sensation during swallowing may also occur in adults with dental covers or dentures. 18. Mistakenly ingesting one's own dentures is not uncommon. 19 Patients with altered mental status or sensorium, including the very old, demented, or intoxicated, are at risk for accidental foreign body ingestions. Fig 28.1. Accidental coin ingestion has been noted in college-aged adults during a tavern beer drinking game called Quarters, in which the coin becomes lodged in the esophagus. 20 Finally, those in certain occupations, e.g., roofers, carpenters, seamstresses, tailors, are at risk of accidental ingestion when nails or pins are held in the mouth during work. The most common groups that intentionally ingest foreign bodies are psychiatric patients and prisoners. 21 In whom ingestion is often done for secondary gain, they often ingest multiple objects multiple times and often the most complex foreign bodies. Iatrogenic foreign bodies are increasing in prevalence because of complications from capsule endoscopy, migrated stents, esophageal, enteral, and biliary, and migrated enteral access tubes and bolsters. 22-23 Esophageal food impaction is the most common GIFB requiring medical attention in the U.S., with an incidence of 16/100,000.24 The vast majority, 75% to 100%, of patients with an esophageal food impaction have an underlying predisposing esophageal pathology. 25-26 Most often peptic strictures, Schatzky rings, and increasingly eosinophilic esophagitis, EOE. 27 Esophageal cancer rarely presents with acute food bolus impaction. 28 Other causes that contribute to esophageal food impactions include altered surgical anatomy following esophagectomy, fundoplication, or bariatric surgery and motility disorders such as achalasia and distal esophageal spasm. 29 Food impactions most commonly occur in adults in their 4th or 5th decade of life but are becoming more prevalent in young adults because of the rising incidence of eosinophilic esophagitis. Cultural and regional dietary habits influence GIFBs. Fishbone injury is common in Asian countries and the Pacific Rim, whereas impactions due to meats, e.g., hot dogs, pork, beef, chicken, are common in the U.S. Fig 28.2. 30-31 Symptomatic rectal foreign bodies are more often the result of insertion through the anus rather than oral ingestion and transit. This is reported most commonly in young adult males. 32 Rectal foreign bodies that come to medical attention are most commonly inserted with the intention of autoeroticism but may present following consensual sexual acts or sexual assault. 33 Less common but still prevalent causes of rectal foreign bodies include concealment of illegal drugs during smuggling efforts, loss of objects during attempts by the patient to relieve constipation, and even reports of falling on objects. 34 Pathophysiology. The majority, 80% to 90%, of GIFBs pass through the GI tract without any clinical sequelae and cause no harm to the patient. 135 The remaining 10% to 20% of GIFBs will require endoscopic intervention, and 1% of GIFBs may require operative therapy. 536 Recent data suggest that in the setting of intentional ingestions, the need for endoscopic and surgical intervention is higher, with endoscopy being performed in 2/3 of cases and surgery needed in greater than 10% of patients. 37 True foreign bodies and food impactions can cause significant morbidity, with the most serious complications being bowel perforation or obstruction and rarely ensuing death. 3 To help stratify therapeutic interventions, it is important to understand the conditions, patients, and anatomic locations in which complications associated with GIFBs are apt to occur. Perforation and obstruction from GIFBs can occur in any part of the digestive tract, but they are more apt to occur in areas of narrowing, angulation, anatomic sphincters, or previous surgery. Fig 28.3. 38 The pharynx is the first area where foreign bodies may become entrapped and cause complications. In the hypopharynx, short sharp objects like fish bones and toothpicks may lacerate the mucosa or become lodged. 39,40 Once in the esophagus, there are 4 areas of narrowing where food boluses and foreign bodies become lodged: upper esophageal sphincter, level of the aortic arch, level of the mainstem bronchus, and esophagogastric junction. These areas all have luminal narrowing to 23 mm or less. 41 However, food and foreign bodies more commonly lodge in the esophagus at areas of pathology, including rings, webs, or strictures. Multiple esophageal rings associated with eosinophilic esophagitis, see Chapter 30, contribute to esophageal food impaction at an increasing prevalence in young adults. 27, 42, 43 Similarly, esophageal motor abnormalities, see Chapter 44, such as distal esophageal spasm or achalasia, may lead to food or foreign body impaction in the esophagus. 44-47 Foreign body and food impaction in the esophagus have the highest incidence of overall adverse events, with the complication rate directly proportional to how long the object is lodged in the esophagus. Esophageal foreign bodies in children have a significantly lower spontaneous passage rate, as low as 12% compared with other GIFBs. 48 Serious complications of esophageal foreign bodies include perforation, abscess, mediastinitis, pneumothorax, fistula formation, and cardiac tamponade. 49, 50 If a GIFB passes through the esophagus, the vast majority will pass through the entire GI tract without further difficulty or complication. Exceptions are sharp, long, and large objects. Sharp or pointed objects may have a perforation rate as high as 35%. Large objects, greater than 2.5 cm 1 inch in diameter, may not be able to pass through the pylorus. Long objects, greater than 5 cm 2 inches, such as pens, pencils, and eating utensils, may not negotiate around the duodenal sweep or through the pylorus. Objects may become impacted in the small intestine at the ligament of Treitz or ileocecal valve. Adhesions, post-inflammatory strictures, and surgical anastomoses within the small intestine may also be sites where foreign bodies lodge and obstruct. However, most objects, even sharp ones, rarely cause damage once in the small intestine and colon, because the bowel naturally protects itself through peristalsis and axial flow. These factors tend to keep the foreign body concentrated in the center of fecal residue, with the blunt end leading and the sharp end trailing. 51, 52 Inserted rectal objects are often tenaciously retained because of anal sphincter spasm and edema, making spontaneous passage of the object difficult. The angulation and valves of Houston may also impede passage of objects through the rectum. History and physical examination. The history from children or non-communicative adults is often unreliable. Most gastric and up to 20% to 30% of esophageal Fig 28.2 endoscopic image of bratwurst with sauerkraut impacted in the esophagus while the patient was tailgating at a football game. Gastroesophageal junction hypopharynx upper esophageal sphincter level of aortic arch pylorus duodenum ileocecal valve rectum and anus Fig 28.3 gastrointestinal areas of luminal narrowing and angulation that predispose to foreign body impaction and obstruction. Chapter 28 Foreign Bodies, Bezoars, and Caustic Ingestions 401 28 Foreign bodies in children are asymptomatic. 53 Most of these present after having been witnessed or suspected by a parent, caregiver, or older sibling, but in up to 40% of cases, there is no history of a witnessed ingestion. 54 Thus, symptoms are often subtle in children, presenting as drooling, not wanting to eat, and failure to thrive. For communicative adults, history of the timing and type of ingestion is usually reliable. Patients are able to relate exactly what they ingested, when they ingested it, and symptoms of pain and/or obstruction. Patients with esophageal food bolus impactions are symptomatic with complete or intermittent obstruction. They are unable to drink liquids or retain their own oral secretions. Sialorrhea is common. Ingestion of an unappreciated small, sharp object, including obscured fish or animal bones, may cause odynophagia or a persistent foreign body sensation because of mucosal laceration. The type of symptoms can aid in determining whether an esophageal foreign object is still present. If the patient presents with dysphagia, odynophagia, or dysphonia, there is an 80% likelihood a foreign body is present, causing at least partial obstruction. Symptoms of drooling and inability to handle secretions are indicative of a near-total esophageal obstruction. If symptoms are restricted to retrosternal chest pain or pharyngeal discomfort, less than 50% of patients will still have a foreign body present. 55 Patient localization of where an ingested foreign object is lodged is not accurate, with only a 30% to 40% correct localization in the esophagus and essentially a 0% accuracy for foreign bodies in the stomach. 53,56 Once the object reaches the stomach, small intestine, or colon, the patient will not report symptoms unless a complication occurs, e.g., obstruction, perforation, bleeding. Patients with rectal foreign bodies are frequently asymptomatic. 33 But embarrassment may interfere with obtaining an accurate history. Presentation is often after the patient or another person has made multiple attempts to remove the object. 39 Symptoms may include anorectal pain, bleeding, and pruritus, with a small number of patients presenting with more serious complications, including obstruction, perforation, and peritonitis. Past medical history is useful to identify previous foreign body ingestion. Repeat offenders are likely to ingest multiple and more complex foreign objects. A history of dysphagia in a person with a food impaction or esophageal foreign body suggests a high likelihood of underlying esophageal pathology. Previous food impaction or need for esophageal dilation makes recurrent episodes more likely. A history of allergies, e.g., asthma, allergic rhinitis, food allergy, may be a clue that a patient may have eosinophilic esophagitis. 57 Physical examination does little to secure the diagnosis or location of a retained foreign body, but it is crucial to identifying already developed complications related to foreign body ingestion. Assessment of the patient's airway, ventilatory status, and risk for aspiration are crucial prior to initiating therapy to remove a GIFB. A neck and chest examination looking for crepitus, erythema, and swelling can suggest a proximal perforation. Lung examination should be performed to detect the presence of aspiration or wheezing. An abdominal examination should be performed to evaluate for signs of perforation or obstruction. Diagnosis imaging plain films of the chest and abdomen are recommended for patients presenting with suspected foreign body ingestion to determine the presence, type, number, and location of foreign objects present. Radiologic evaluation is not routinely needed for patients with non-bony food impactions who have no complications. 58 Both anteroposterior and lateral chest films are needed because lateral films will aid in determining if a foreign body is in the esophagus or the trachea. 59 And may detail foreign bodies obscured by the overlying spine in an anteroposterior film. Biplanar neck films are recommended if there is a suspected object or complication in the hypopharynx or cervical esophagus. Plain films are also useful in identifying complications like free air, aspirations, or subcutaneous emphysema. Fig 28.4.60 Unfortunately, radiography cannot image non-radiopaque objects, e.g., plastic, glass, wood, and may miss small bones or metal objects. The false negative rate for plain film investigation of foreign bodies is as high as 47%, with false positive rates up to 20%. False negative rates for food impactions have been reported as high as 87%. 61 If continued clinical suspicion or symptoms warrant, the individual should undergo further clinical investigation. 62 Use of plain films in children is more controversial because of the inability of the child to give a history and the associated radiation exposure. Some have suggested mouth-to-anus screening films to detect the presence of foreign bodies in children. Bedside US has been effective in identifying esophageal foreign bodies in children without the need of radiation. 63,64 Also to limit radiation, handheld metal detectors have been used, with the sensitivity ranging from 89% to 95% for detection and localization of metallic foreign bodies. 65,66 Barium studies are generally not recommended for evaluating GIFBs. Aspiration of hypertonic contrast agents in patients with complete or near-complete esophageal obstruction may lead to aspiration pneumonitis. 67 Barium may also delay or impair the performance of a therapeutic endoscopic intervention by interfering with endoscopic visualization. 68 Even if a barium study is considered normal, an endoscopy is still recommended if symptoms persist or suspicion of a foreign body is high. 39 CT or MRI are rarely necessary for the diagnosis of GIFBs. However, CT has been found to detect foreign bodies missed by other modalities. 69 And may aid in detecting complications of foreign body ingestion, such as perforation or abscess, prior to the use of endoscopy. 70 CT of the cervical esophagus or hypopharynx prior to endoscopic investigation may benefit diagnosis. 71 Endoscopy provides the most precise means to diagnose suspected foreign bodies or food impactions. This ensures an almost 100% diagnostic accuracy for objects within the reach of the endoscope, including non-radiopaque objects and objects obscured by overlying bony structures that are not visualized by radiography. Fig 28.4 Chest film demonstrating pneumomediastinum and bilateral pneumothoraces in a patient who developed esophageal perforation secondary to a food impaction left untreated for longer than 24 hours. 402 Part 4 Topics involving multiple organs. Endoscopy allows the most accurate diagnosis of the underlying pathology, such as esophageal strictures, which may have led to a food impaction or impacted esophageal foreign body. Endoscopy also allows visualization of mucosal defects, abrasions, or ulcerations that may have resulted from the foreign body. Diagnostic endoscopy is also linked to the most efficacious therapy for GIFBs, the use of therapeutic endoscopy to remove or treat the object. Diagnostic upper endoscopy for foreign bodies is relatively contraindicated when there are clinical or radiographic signs of perforation. Once an ingested foreign object has passed the ligament of Treitz, endoscopy is generally not indicated, because these objects will typically pass unimpeded with notable exceptions, see later. Similarly, most small, 2.5 centimeters, blunt objects in an adult patient's stomach do not require endoscopic retrieval, most will pass without complication. Treatment non-endoscopic methods. Treatment of GIFBs should always be planned with the knowledge that 80% to 90% of GIFBs will spontaneously pass through the GI tract without complication. 5,8 This has led some investigators to suggest that all foreign bodies can be managed with conservative observation. 72,73 Although conservative management is effective in most cases of GIFB, it is more appropriate to perform selective endoscopy for treatment based on the location, size, and type of foreign Body ingested 21,74. Several medical therapies have been considered as primary treatment of esophageal foreign bodies and food impactions. The smooth muscle relaxant glucagon is the most widely used and studied drug for the treatment of esophageal food and foreign object impactions. Glucagon, given in intravenous doses of 0.5 to 2 mg, can produce relaxation of the lower esophageal sphincter by as much as 60%, with the potential to permit passage of the impacted food or foreign body. 75,76 Success with glucagon ranges from 12% to 58% in treating food impactions. 77-79 A multi-center study showed glucagon to be effective in only 14% of cases, not statistically different from patients who did not receive glucagon. 80 A small randomized study showed no benefit of glucagon administration over placebo. 81 Glucagon may cause nausea, vomiting, and abdominal distension and has little effect when a fixed obstruction is present, preventing passage of the foreign body. Nifedipine and nitroglycerin are not recommended because of hypotension-related side effects and questionable efficacy. Gas-forming agents like carbonated beverages or preparations consisting of sodium bicarbonate and citric acid have been described for treating esophageal impactions. They are purported to release carbon dioxide gas to distend the lumen and act as a piston to push the object from the esophagus into the stomach. 82 However, the effectiveness of this method is doubtful, and perforations have been reported associated with use of gas-forming objects. 83 Similarly, the meat tenderizer papain is not recommended for treatment of esophageal meat impactions. Its lack of efficacy and risk of complications, e.g., perforation, mediastinitis, have been described. 84,85 Radiologic methods to treat esophageal foreign bodies are often successful. Under fluoroscopic guidance, Foley catheters, suction catheters, wire baskets, and magnets have been used to retract objects. 60 The most commonly described extraction device is the Foley catheter. Its tip is passed beyond the object, the balloon inflated, then the object is withdrawn into the oropharynx. Success with this method under fluoroscopy has been described as better than 90%. However, all radiographic methods suffer from lack of control of the object, particularly at the level of the upper esophageal sphincter and hypopharynx. Complications include nosebleeds, laryngospasm, aspiration, perforation, and even death. 86 Radiographic methods are generally recommended only if flexible endoscopy is unavailable. Endoscopic methods. Flexible endoscopy has become the treatment of choice for GI food impactions and foreign bodies because it is safe and highly efficacious. Multiple large series have reported the success rate for endoscopic treatment of GIFBs to be more than 95%, with complication rates of less than 5%. 536, 66, 74, 87-89 The risk for complications is increased when sharp or multiple objects are ingested and when ingestion is intentional as opposed to accidental. Because most GIFBs pass spontaneously without causing symptoms, it is important to understand the indications and timing for endoscopic intervention. Generally, all foreign bodies lodged in the esophagus require urgent intervention. The risk for an adverse outcome from an esophageal foreign body or food impaction is directly related to how long the object or food dwells in the esophagus. 90 Ideally, no object should be left in the esophagus longer than 24 hours. Once in the stomach, most ingested objects will pass spontaneously, and the risk of complications is much lower, making observation acceptable. There are notable exceptions. Sharp and pointed objects are associated with perforation rates as high as 15% to 35%. 90 Objects longer than 5 cm and round objects wider than 2.5 cm also may not be passed and should be removed from the stomach with an endoscope at presentation or if they have not progressed in 3 to 5 days. If a more complex or sharp object has progressed beyond the stomach and cannot be retrieved, periodic radiographs should be obtained to document progression through the GI tract. 91 The patient should then be followed for any symptoms suggestive of obstruction or perforation, e.g., fever, tachycardia, abdominal pain, distension. Alternatively, with the increasing use of double and single balloon enteroscopy, case reports have detailed the use of these scopes to safely and effectively retrieve foreign bodies from the small bowel. 92,93 Given that most foreign bodies pass without sequelae upon reaching the small intestine, use of balloon-assisted enteroscopy should take into consideration the type of object and the patient who ingested it. Accessories including baskets, hoods, and forceps have been designed for balloon enteroscopes to enable foreign body retrieval. Sedation to facilitate endoscopy for the management of food impactions and ingested foreign objects should be individualized. Conscious sedation is adequate for treating most food impactions and simple foreign bodies in the adult population, but anesthesia assistance may be required for uncooperative patients or patients who have swallowed multiple complex objects. See Chapter 42. Endoscopy for treatment of foreign bodies in the pediatric population is usually performed with the aid of anesthesia and endotracheal intubation. 94 For management of impactions and ingestions below the level of the laryngopharynx, flexible endoscopy is preferred. 95 Rigid esophagoscopy and flexible nasoendoscopes can be used but provide no additional benefit and are often available to only a few endoscopists. 7,96 A comparison of rigid versus flexible endoscopes to treat esophageal foreign bodies found significantly fewer perforations with flexible endoscopes. 97 Laryngoscopes with the aid of a Kelly or McGill forceps can be useful for proximal foreign bodies and small sharp objects in the hypopharynx. Availability of and familiarity with multiple endoscopic retrieval devices for removal of foreign bodies and food impactions is critical. Box 28.1. An endoscopy suite and/or travel cart should be equipped with at least rat tooth or alligator grasping forceps, polypectomy snare, dormia basket, and retrieval net. 98 Overtubes of 45 and 60 cm in length should be available to the endoscopist. An overtube allows protection of the airway, multiple exchanges of the endoscope, and mucosal protection from Chapter 28 Foreign Bodies, Bezoars, and Caustic Ingestions. 403 28 Sharp Objects. 99 The longer 60 cm overtube enables retrieval of sharp and complex objects from the stomach and encompasses the lower esophageal sphincter. An alternative adjunct for extraction of sharp objects is a latex protection hood that fits onto the tip of the endoscope, discussed later. 100,101 When planning for extraction of complex, sharp, or pointed objects that were ingested, and when opportunity permits, it may be valuable to go through an ex vivo dry run on a similar object when considering retrieval devices and extraction technique. 5 Success and speed of retrieval of the foreign body have been shown to be directly related to endoscopist experience. 102 When personnel or facilities are not available to accomplish relief endoscopically, consideration should be given to transferring the patient to another center. Specific foreign bodies. Food impaction. Food impaction is the most common ingested foreign body in the U.S. 29 The most common foods to cause impactions in the U.S. are meat products, including beef, hot dogs, and chicken. Fishbone impactions are more common in coastal areas and Asian countries. Imbibing alcohol while eating large cuts of meat may increase the risk for food impactions and has led to the terms backyard barbecue syndrome and steakhouse syndrome. Given that food boluses may pass spontaneously, the need for endoscopic intervention is based on the persistence of symptoms. Patients with signs of complete or near-complete obstruction with drooling or excessive salivation should undergo urgent upper GI endoscopy. Endoscopic intervention should be achieved at the latest within 24 hours of onset of symptoms and more ideally within the first 6 to 12 hours. Longer duration of the food impaction may decrease the endoscopy success rate. 103 An increased risk for complications is thought to be proportional to the duration of esophageal food impaction. 1, 18, 104 The primary method to treat food impaction is the push method, with success rates well over 90% and minimal complications. 25 Before the food impaction is pushed into the stomach, an attempt to steer the endoscope around the food into the stomach should be made. Generally, if the endoscope can be passed around the food impaction into the stomach, the impaction can be safely pushed into the stomach without difficulty. This also allows assessment of any obstructive esophageal pathology beyond the impaction. Even if the endoscope cannot steer around the food impaction, gentle pushing pressure can be safely attempted. Larger boluses of impacted meat can be broken apart with the endoscope or an accessory prior to safely pushing the smaller pieces into the stomach. EOE has increasingly been associated with esophageal food impactions, Fig 28.5, see Chapter 30. Food impactions tend to occur more frequently in EOE patients with visible endoscopic rings and higher eosinophil density on biopsy. 105 reports indicate that food impaction in patients with EOE can be treated effectively and safely with the push method. 42 but care should be taken to minimize inducing mucosal tears. 106 While perforation is overall low with EOE, the majority of these perforations occur with a prolonged food bolus impaction. 107 Particular care should be taken when using rigid endoscopes if eosinophilic esophagitis is suspected. Perforation rates with rigid scopes in this patient population have been reported as high as 20%. 108 If EOE is suspected, mucosal biopsies should be obtained after the food impaction is treated. However, only 34% of endoscopists take esophageal biopsies at time of food impaction, significantly decreasing the chance for diagnosis and proper treatment. 109 Treatment of EOE with topical glucocorticoids reduces the risk of subsequent food bolus impactions. 110 Food impactions that cannot be gently pushed into the stomach must be dislodged and withdrawn. Retrograde removal can be achieved with various retrieval devices, including snares, baskets, nets, and forceps. Initial manual disruption of the food bolus into smaller pieces typically makes removal easier. An esophageal overtube is useful in such cases because it protects the airway and allows multiple exchanges of the endoscope during retrieval. A dedicated food bolus retrieval net can be useful for removing large pieces of food without the use of an overtube, because the food can be satisfactorily secured within the net, reducing the risk of aspiration of the ingestate. 111 All pull methods can also be used effectively and safely in EOE patients, but care should be taken when placing overtubes, particularly in patients with a narrow caliber esophagus. Transparent plastic hoods or caps, such as those used to perform variceal band ligation and endoscopic mucosal resection, have been successfully used to remove large, tightly impacted meat boluses. Use of the cap may be a more effective method with less complications than using other devices to pull out the food impaction. 112 With the cap secured to the tip of the endoscope, the device can be used to suction the food into the vacuum chamber and withdraw the bolus per os. 113,114 More than 75% of patients with food impactions have associated esophageal pathology. 5,26 And about half of patients with Box 281 equipment for treatment and removal of gastrointestinal foreign bodies and food impactions. Endoscopes: flexible endoscope, rigid endoscope, laryngoscope, overtube, standard esophageal overtube 45 to 60 cm, foreign body overtube, accessory equipment, retrieval net, grasping forceps, dormia basket, polypectomy snare, transparent vacuum cap, latex protector, hood, Kelly or McGill forceps. Fig 28.5 Food impaction in a patient with multiple concentric rings and known diagnosis of eosinophilic esophagitis. 404 Part 4 Topics involving multiple organs. Food bolus impactions have abnormal 24-hour esophageal pH studies and/or esophageal manometry. If an esophageal stricture or Schatzky ring is present after the food bolus is cleared, it can be safely and effectively dilated concurrently if circumstances allow. More often, mucosal abrasions or erythema from the food dwelling in the esophagus for an extended period exists, and dilation is delayed for 2 to 4 weeks, during which patients should be prescribed proton pump inhibitor therapy. When multiple esophageal rings are present, biopsies should be obtained to evaluate for eosinophilic esophagitis. Lack of appropriate follow-up for patients, particularly those with strictures or rings, has been shown to be a predictor for recurrent food impactions. 115 Sharp and pointed objects. Sharp and pointed objects may cause a perforation in up to 15% to 35% of patients and account for 1/3 of all perforations from GI foreign bodies, with a 2.5-fold greater risk of complications compared to other GIFB. 116,117 Sharp and pointed objects, particularly toothpicks and animal bones, are the most likely ingested foreign objects to cause a perforation that necessitates surgical management. 118 Patients with psychiatric illness and incarcerated patients are more likely to ingest more complex and multiple sharp and pointed objects, such as razor blades, Fig. 28.6, pins, needles, and writing and eating utensils, Fig. 28.7. Sharp and pointed objects retained in the esophagus are considered a medical emergency and should be removed within 6 to 12 hours. Moreover, any sharp and pointed object within the reach of the endoscope should be removed as well if this can be safely done, Fig. 28.8. When removing sharp and pointed objects, the foreign body should be grasped and oriented so that the pointed end trails on withdrawal to reduce the risk of perforation and mucosal laceration. 119 For sharp and pointed objects, retrieval is best achieved with a grasping forceps, polypectomy snare, or biliary stone retrieval basket. 102 All these devices can secure the object, orient the device with the sharp end pointing distally as described earlier. Retrieval nets tend to shear in the removal of sharp objects and may compromise visualization. Use of an overtube should be considered to protect the esophagus and pharynx. Long, pointed objects can be grasped and directed into the overtube. The entire assembly, including the sharp and pointed object, endoscope, and overtube, are then removed in unison. An alternative to an overtube for the extraction of sharp and pointed objects is a retractable latex hood that can be affixed to the tip of the endoscope, Fig. 28.9. When the endoscope is pulled back through the lower esophageal sphincter, the hood flips over the grasped object and protects the mucosa during withdrawal. 100,120 Although associated with an increased risk of perforation, most sharp or pointed objects beyond reach of the endoscope will pass unimpeded and be eliminated through the GI tract without complication. Because of the increased risk of perforation, sharp and pointed objects should be followed by serial daily radiographs to ensure progression. If a sharp or pointed object fails to progress over 3 days, operative intervention should be considered. Long objects ingested objects longer than 5 cm, 2 inches, especially those longer than 10 cm, 4 inches, have difficulty passing through the pylorus and duodenal sweep and can get hung up, causing obstruction or perforation at these locations, see Fig. 28.8. The most commonly ingested long objects are pens, pencils, toothbrushes, and eating utensils. Grasping forceps and polypectomy snares are the most commonly used devices to secure and remove long objects. Long objects should be grasped at one end and oriented longitudinally to permit removal. For extraction of long objects, use of the 60 cm overtube endoscope assembly, as described earlier, should be considered. Blunt objects, coins, batteries, and magnets. Small blunt objects, such as pieces of toys and coins, are the most commonly ingested objects by children. Disc, button, battery and AB. Fig. 28.6a, a razor blade, in the stomach, ingested by a prisoner. B. Removal of the razor blade with a grasping forceps and overtube. Nail spoon. Fig. 28.7 endoscopic image of a nail and a long spoon that became impacted in the duodenal sweep after being swallowed by a psychiatric patient. Chapter 28 Foreign bodies, Bezoars, and Caustic Ingestions. 405 28 Magnet ingestions are uncommon but pose unique potential dangers. Blunt objects in the esophagus should be removed promptly. Impacted coins can result in pressure necrosis of the esophageal wall, resulting in perforation and fistula. A coin of any size can become lodged in the esophagus of children, but ingested coins in particular, dimes and pennies measuring 17 and 18 mm will usually pass through the adult esophagus. Coins located in the distal esophagus on imaging are twice as likely as coins in the proximal esophagus to pass spontaneously. 121 Polyp or dedicated retrieval nets allow capture and secure removal of coins and most small blunt objects. 102 Grasping forceps and biliary stone retrieval baskets are also effective. Standard biopsy forceps and snares are not recommended because they fail to secure coins reliably during extraction. If it is difficult to capture a blunt object in the esophagus, it is safe to push the object into the stomach, where there is more room to negotiate. Once a small blunt object enters the stomach, conservative outpatient management is appropriate for many patients. 122 Exceptions to this include patients with surgically altered digestive tract anatomy and those who have ingested large blunt objects. In adults, The pylorus will allow passage of most blunt objects up to 25 mm in diameter, which includes all coins except half dollars, 30 mm, and silver dollars, 38 mm. Otherwise, once in the stomach, a regular diet is appropriate, with radiographic monitoring every 1 to 2 weeks to confirm progression or elimination. If after 3 to 4 weeks a blunt object has not passed, endoscopic removal should be performed. 123 Disc batteries are now contained in many small toys and electronic devices accessible to young children. Disc battery ingestion is of particular concern because batteries contain an alkaline solution that can cause rapid liquefaction necrosis in the esophagus. Disc battery ingestion occurs most commonly in younger children, with roughly 10% becoming symptomatic. 124 Any clinical suspicion of a disc battery in the esophagus should prompt emergent endoscopy. Most button batteries will be identified on plain films prior to endoscopy, with larger batteries, greater than 2 cm, more likely to remain in the esophagus and cause complications. 125 Grasping forceps and snares are generally ineffective for disc battery removal, but use of a retrieval net permits successful removal in almost 100% of cases. 126 Protection of the airway with an overtube or, in pediatric patients, endotracheal intubation is crucial in retrieval of disc batteries. Half of patients with disc batteries in the stomach have mucosal damage, and thus gastric batteries should also be removed via the endoscope. 127 Once in the small intestine, disc batteries rarely cause clinical problems and can be observed radiographically, with 85% passing through the GI tract within 72 hours. 128 Cylindrical batteries appear to cause symptoms less frequently, with no reports of major life-threatening injuries and only 20% having some minor symptoms after ingestion, including mucosal ulceration and rarely bowel obstruction. 128 Cylindrical batteries should be removed from the esophagus and, if in the stomach, ones larger than 20 mm or batteries that have not progressed in 48 hours should be removed by endoscope. Fig 28.10. Small coupling magnets have become popular as children's toys. Ingested magnets within the reach of the endoscope should also be removed on an urgent basis. Although a single magnet will rarely be a cause of symptoms, concern exists if multiple magnets are ingested or if magnets were ingested with other metal objects. This can result in magnetic attraction and coupling between interposed loops of bowel, with subsequent pressure necrosis, fistula formation, and bowel perforation. 129,130 Removal should be performed urgently when the magnets are likely to be within reach of a standard endoscope. This can be achieved with grasping forceps, retrieval net, or basket. Magnetic attraction to metallic retrieval devices may ease the task of removal. AB Fig 28.8 Endoscopic images of shards of broken glass in the prepyloric antrum. Courtesy Dr. Jamie Anderson and Dr. Tushar Dharia, Dallas, Texas. Fig 28.9a, a latex protector hood with the hood pulled back. This position enables full visualization and allows the endoscopist to grasp a sharp object easily. B. As the protector hood is pulled back through the lower esophageal sphincter, the hood flips forward, protecting the GI mucosa from the sharp object. AB 406 Part 4 Topics involving multiple organs. Narcotic packets. Ingested packets of illicit narcotics in the GI tract present in two general groups, body stuffers and body packers. Body stuffers are drug users or traffickers who quickly ingest small amounts of drugs, but in poorly wrapped or contained packages that are prone to leakage. Body packers are mules used by drug smugglers for drug transport. They ingest large quantities of carefully prepared packages intended to withstand GI transit. 131,132 These patients may present with intestinal obstruction due to the packages or with symptoms related to the drug ingested. The latter may result in serious toxicity and death in 5% of individuals. 133 Suspected patients are typically uncooperative and accompanied by law enforcement agents. Diagnosis is initiated with plain film radiology or CT scan, with multiple round or tube-shaped packets seen. Endoscopic removal is contraindicated because of the high risk of package perforation, with resultant drug overdose. 1 Observation on a clear liquid diet is recommended with serial radiographs. Operative intervention is indicated when bowel obstruction, failure to progress, or drug leakage/toxicity is suspected. In a large study, up to 45% may require surgery with gastrotomy, enterotomy, or colotomy performed based upon the location of the packages. 134 Other data has suggested that conservative therapy of narcotic packers with just observation led to surgery in less than 3% of cases. 135,136 Colorectal foreign bodies. Ingested objects uncommonly become lodged in the colorectum. More commonly, colorectal foreign bodies were inserted into the rectum intentionally or unintentionally. Radiographs should be obtained prior to attempting removal of colorectal foreign bodies for better visualization of the location, orientation, and configuration of the object. Fig 28.11. To avoid healthcare provider injury, attempts at manual removal or digital rectal examination should be deferred until the presence of a sharp or pointed object has been excluded. Manual digital extraction may be successful for the removal of small, blunt, palpable objects in the distal rectum. Conscious sedation may be adequate for manual removal in some patients, but examination and extraction under general anesthesia may be required in others to allow greater anal sphincter relaxation and successful object extraction. Non-palpable and sharp or pointed objects should be removed under direct visualization with the use of a rigid proctoscope or flexible sigmoidoscope. 137 Standard retrieval devices can be used as described earlier for the upper digestive tract. A latex hood or overtube can be particularly useful in removing long, sharp, pointed objects to protect the rectal mucosa from laceration and to overcome the tendency of the anal sphincter to contract on attempted removal of objects. Although conscious sedation will often facilitate removal, general anesthesia can allow maximum dilation of the anal sphincter to help remove larger and more complex objects. 138 Operative intervention is indicated for any suspected complications secondary to a rectal or colon foreign body, including perforation, abscess, and obstruction. Complications are more common when the object is proximal to the rectum. 139 Procedure-related complications. Although the reported complication rate associated with endoscopic removal of GIFBs and food impactions is low, 0% to 1.8%, it is thought to be much higher in practice. 5,9, 24, 25, 36, 68 Perforation is the most feared complication, although aspiration and sedation-related cardiopulmonary complications may also occur. See Chapter 41. Factors that increase the risk for complications include removal of sharp and pointed objects, an uncooperative patient, multiple and/or deliberate ingestion, an extended duration of time from food impaction or foreign body ingestion. 12 Bezoars. Bezoars are collections of indigestible material that accumulate in the GI tract, most frequently in the stomach. The three most common types of bezoars encountered are phytobezoars, composed of vegetable matter, trichobezoars, made up of hair or hair-like fibers, and medication bezoars, pharmacobezoars. Fig 28.11 and Box 28.2. Fig 28.10 Multiple cylindrical batteries greater than 2 cm found in stomach and subsequently removed with the endoscope. 52.13 mm 229.20 mm supine. Fig 28.11 Plain film showing a self-introduced rectal foreign body in a 73-year-old man presenting with lower abdominal pain. Courtesy Drive. William Bojan, Plano, Texas. Chapter 28 Foreign Bodies, Bezoars, and Caustic Ingestions. 407 28 Epidemiology. Phytobezoars are the most common type of bezoar. Offending fruits and vegetables include celery, pumpkin, prunes, raisins, leeks, beets, and persimmon. 5 All these foods contain large amounts of insoluble and indigestible fibers such as cellulose, hemicellulose, lignin, and fruit tannin. 140 A phytobezoar develops when large quantities are ingested and accumulate. Trichobezoars occur most commonly in young women and children from ingestion of large amounts of hair, carpet fiber, or clothing fiber. Trichobezoars are more often associated with psychiatric disorders, mental retardation, or pica. 141 Medication Bezoars occur with fiber-containing medications, resin water products, or extended-release medications designed to resist digestion. 142 Medication Bezoars can result in decreased pharmacologic efficacy when the active agent is trapped in the bezoar and cannot be absorbed, or, alternatively, toxicity when the contents of a large gastric medication bezoar are released all at once into the small intestine. The clear majority of patients with bezoars, other than trichobezoars, have a predisposing factor that decreases emptying of gastric contents. Prior gastric surgery is evident in as many as 70% to 94% of patients with bezoars. Retained gastric contents may be observed in up to 65% to 80% of patients who have undergone a vagotomy with pyloroplasty. 56 Bezoar formation after gastric surgery results from delayed gastric emptying, decreased gastric accommodation, and reduced acid peptic activity. 143 Gastroparesis is commonly seen in patients with gastric bezoars. Patients with diabetes or end-stage renal disease and patients on mechanical ventilation are at greater risk for bezoar formation. 144 Clinical features. Patients with gastric bezoars may be asymptomatic, but most, 80%, have vague symptoms of epigastric discomfort. 144 Associated anorexia, nausea, vomiting, weight loss, and early satiety may also be present. Bezoars can cause gastric ulceration secondary to pressure necrosis. Bezoar-induced gastric ulcers can cause bleeding and gastric outlet obstruction. 145 Bezoars may also accumulate in the small bowel and usually present with mechanical obstruction. Rapunzel syndrome is a term used to describe trichobezoars located primarily in the stomach that extend past the pylorus and into the duodenum, causing bowel obstruction or even jaundice or pancreatitis because of obstruction at the level of the ampulla of Fata. 146,147 Diagnosis. The history is helpful in the diagnosis of bezoar, with a focus on the amount and types of food or medications consumed. A history of previous bezoar, gastric surgery, or gastric dysmotility should be considered. Physical examination usually assists little in the diagnosis, although occasionally a palpable abdominal mass may be appreciated. Halitosis due to the putrefying materials of the bezoar residing in the stomach may be present. Baldness and a patchy hair pattern may be present in patients who suffer from trichotillomania. They are consistently ingesting their own hair. A plain abdominal radiograph may demonstrate the outline of the bezoar. On contrast radiography, a gastric bezoar classically presents as filling defects within the stomach. 140 Plain films and contrast studies will detect only 25% of bezoars detected at upper endoscopy. CT scan may aid in identifying small bowel bezoars and predict, based on size and degree of vegetable matter the bezoar is made of, whether an obstruction will occur. 148 Gastric bezoars are more definitively diagnosed with upper endoscopy. Phytobezoars are seen as a dark brown, green, or black mass of amorphous vegetable material in the stomach. Trichobezoars tend to have a hard, blackened, and almost concrete appearance. Medication bezoars will be seen as whole pills or pill fragments in the midst of the material. Fig 28.12. Treatment. Smaller bezoars may be treated with conservative medical management. Usually this consists of a liquid diet for a short period of time and a prokinetic agent to promote gastric emptying. 140 Chemical dissolution, most commonly with cellulase, has been reported successful in up to 85% of patients with small bezoars. 145 Cellulase can be taken as a tablet or instilled into the stomach as a liquid via an endoscope or nasogastric tube. Nasogastric lavage may aid in the physical dissolution of small bezoars. Carbonated soda, e.g., Coca-Cola, may be effective in the dissolution of over 50% of cases of phytobezoars and over 90% when combined with endoscopic methods. 148 Additional medications that have been shown to effectively treat gastric bezoars include pancreatin and ursodeoxycholic acid, alone or in combination with cellulase and carbonated beverages. 149 For larger bezoars and bezoars resistant to medical therapy, endoscopic therapy may be effective. The endoscope is used to fragment the bezoar into smaller pieces. Fragmentation can be performed with the endoscope itself, with accessory devices like forceps or snares, or with installation of saline or water flushes. Box 282 Oral pharmacologic agents associated with medication. Bezoar formation. Non-absorbable antacids. Bulk laxatives. Cardiovascular medications. Nifedipine, verapamil, procainamide. Vitamins and minerals. Vitamin C, vitamin B1, 2 ferrous sulfate. Miscellaneous agents. Sucralfate, guar gum, cholestyramine. Enteral feeding formulations. Theophylline, sodium polystyrene sulfonate, K-oxalate, resin. Fig 28.12 Endoscopic image of a pharmacobezoar in a patient with a history of a pancreaticoduodenectomy who had obstructive symptoms. The pills were removed with an endoscopic net, with subsequent relief of the patient's symptoms. 408 Part 4 Topics involving multiple organs through the endoscope. The fragments of the bezoar can be pushed into the small bowel or removed by mouth. If most of the bezoar is to be removed, an overtube is recommended to facilitate frequent passes of the endoscope and to protect the airway. Mechanical disruption and endoscopic removal will be successful in 85% to 90% of gastric bezoars. Resistant gastric bezoars may be treated with mechanical lithotripsy, electrohydraulic lithotripsy, ND, YAG laser, or a needle knife sphincterotomy. 150-152 Operative intervention may be needed if endoscopic therapy fails or if there is a complication related to the bezoar, e.g., perforation, obstruction, bleeding. Trichobezoars more often require surgery than phytobezoars. Gastric bezoars are usually removed via a small gastrostomy. 145-147 Small bowel bezoars are removed via an enterotomy or can be transmurally milked to the cecum, where they rarely cause a problem in the larger diameter colon. Laparoscopic removal can first be attempted in bezoar removal, but conversion to an open surgery may occur in just over half of patients. 153 When operative intervention is contemplated, care must be made to exclude multiple bezoars in more than one location. Preventing bezoar recurrence is as important as active treatment. If the underlying causes of bezoar formation are not corrected, recurrence is likely. Avoidance of high fiber and other non-digestible foods should be followed. A starting dose of cellulase, an enzymatic dissolution medication, can be taken prophylactically by patients who have frequently recurring bezoars. Prokinetic drugs may be useful for patients with underlying motility disorders. In particularly refractory patients with recurring gastric bezoars, repeated periodic endoscopy with physical disruption of food material may prevent larger and clinically significant bezoar formation. Caustic ingestions. Epidemiology. Some 5,000 caustic ingestions are reported annually in the U.S. 154 Most occur as accidental ingestions by children younger than 6 years. 155 Caustic ingestions in adults occur as suicide attempts, in patients with mental health problems, and in the intoxicated person as a result of alcohol or recreational drug ingestion. Adults can ingest larger amounts of caustic substances, so they tend to have more serious injuries than children, who will typically spit out or throw up the caustic agent they swallowed. Broadly, two types of caustic agents are most commonly ingested: alkali agents or acidic agents. Alkali agents are most commonly in household cleaners like drain, toilet bowl, and oven cleaners. Lye is an alkali ingestion that contains sodium or potassium hydroxide. Alkali solutions are often odorless and tasteless, which can result in large amounts being swallowed accidentally. Finally, as noted, disc batteries may also cause alkali-induced damage. Acid ingestion usually comes from swallowing toilet bowl cleaner, swimming pool cleaner, or battery acid. Acid ingestion often causes immediate pain, which results in the agent being rapidly expelled. Household bleach may contain both acid and alkali products but rarely causes severe injury because of their diluted concentration. Pathophysiology. Alkaline ingestion causes a liquefactive necrosis that very rapidly extends through the mucosa, submucosa, muscularis of the esophagus, and stomach. 156 Vascular thrombosis occurs following the necrosis. The initial alkali injury can be transmural and result in perforation, mediastinitis, and peritonitis. 157 External sloughing and ulceration occur a few days after ingestion. Finally, extensive granulation tissue, fibroblastic activity, and collagen deposition occur over weeks, leading to chronic stricture formation. Fig 28.13. With alkali ingestion, the esophagus is most affected. Neutralization by gastric acid limits damage in the stomach. A minority of patients have damage in the small intestine as well. 158 The degree of injury is also dependent on the agent ingested, its quantity, and how long the GI tract was exposed. 159 Acid-acidic agents cause a coagulative necrosis, with thromboses of mucosal blood vessels and a more limited superficial necrosis. Acidic agents are more apt to damage the stomach, particularly the antrum, more than the esophagus. Fig 28.14. Acidic agents tend to be ingested in smaller quantities because of their offensive taste and immediate pain, so they are associated with less overall damage than alkali agents. Clinical features: patients may present with oropharyngeal pain, epigastric pain, chest pain, dysphagia, or odynophagia. Oropharyngeal involvement can cause sialorrhea and drooling. Hoarseness, stridor, and dyspnea suggest injury to the epiglottis, larynx, and upper airway. Persistent chest or back pain may suggest esophageal perforation and mediastinitis, whereas severe abdominal pain can be related to gastric perforation and peritonitis. Of importance is that early signs and symptoms do not always correlate with the amount of caustic injury and likelihood for late complications. 160 On physical examination, patients may have evidence of burns to the oral cavity, with edema, ulceration, and exudate, but as many as 20% to 45% of patients will have normal physical examinations. 161 Diagnosis: radiologic images such as chest X-ray and abdominal films will not aid in the direct diagnosis or grading of severity of injury. Fig. 28.13 Barium esophagogram showing a stricture in the upper esophagus, with narrowing of the mid-esophagus, several weeks after a caustic ingestion. Courtesy Dr. Robert N. Burke, University of California, San Diego, California. Chapter 28 Foreign bodies, Bezoars, and caustic ingestions. 409-28 But will indicate the presence of perforation by showing a pneumomediastinum, pneumothorax, or pneumoperitoneum. CT of the neck, chest, and/or abdomen should be considered when a high degree of suspicion remains for perforation, despite negative plain films. If perforation is present, surgery rather than endoscopy should be performed emergently. Fig. 28.15. Symptoms and the physical examination may not match the degree of injury after a caustic ingestion, so an upper endoscopy examination should be performed in the first 24 to 48 hours after ingestion in patients without perforation. 162 An upper endoscopy allows diagnosis of injury to the GI tract, permits grading of the degree of injury, establishes a prognosis, and can guide therapy. See Fig. 28.15. A relook endoscopy at 5 days post-ingestion may be performed as well, as it can better predict esophageal and gastric complications than an endoscopy performed in the first 24 hours. 163 It is important to note that 40% to 80% of patients with a reported caustic ingestion will have no evidence of injury on endoscopic examination. 164 Emergency CT scan can also be used to grade esophageal injury at time of caustic ingestion and predict stricturing. 165 The degree of injury seen on endoscopic examination can be graded and provides prognostic information. Table 28.1. Grades I and IIA burns, which correspond to first and second degree burns, will usually heal without sequelae. 158 However, strictures will develop in 70% to 100% of patients with grade IIB injury, which causes circumferential ulceration, and grade 3 injury with associated necrosis. 166 Grade 4 injury with perforation carries a mortality rate of up to 65% and requires urgent surgery. Treatment: initial management should address the ABCs of resuscitative management, airway, breathing, and circulation. Regional poison control should be contacted at 1-800-222-1222. Once initially stabilized, management is based on the clinical status of the patient and grade of injury seen on endoscopy. Asymptomatic patients who have a normal endoscopic examination or only grade I or IIA injury can be started on oral intake in the first 24 to 48 hours and usually discharged within that same time frame. Clinically ill patients with hypotension, respiratory distress, and grade IIB, circumferential ulceration, or 3 necrosis on endoscopy should be admitted to an intensive care unit and managed with intravenous fluid resuscitation and close monitoring for evidence of perforation. Laryngoscopy should be performed in patients with respiratory distress. A patient with an edematous, necrotic laryngopharynx should not undergo endotracheal intubation and will need a tracheotomy to maintain an airway. AB Fig 28.14 Caustic injury to the esophagus and stomach by acid. A. After the ingestion of acid, the squamous mucosa of the esophagus has sloughed in a linear pattern. The esophageal mucosa is edematous and has a bluish discoloration. B. The gastric mucosa in this patient is hemorrhagic and edematous. From Wilcox M.C. Atlas of Clinical Gastrointestinal Endoscopy. Philadelphia, W. B. Saunders, 1995. p. 85. Acute caustic ingestion airway management and resuscitation chest and abdominal radiographs perforation EGDI or IIA IIB or IL for no therapy surgery observe for perforation and stricture formation, with appropriate therapy grade of injury Fig 28.15 Algorithm for the approach to acute caustic injury. For the definitions of endoscopic grades of injury, see Table 28.1. Table 28.1 Endoscopic grades of caustic injury grade endoscopic findings I edema and erythema IIA hemorrhage, erosions, blisters, ulcers with exudate IIB circumferential ulceration 3 multiple deep ulcers with brown, black, or gray discoloration 4 perforation 410 Part 4 Topics involving multiple organs emergency surgery with esophagectomy or gastrectomy is required for perforation. Colonic interposition is sometimes required. Operator and institutional experience affects mortality and morbidity of emergent esophagogastrectomy and is best undertaken at referral centers when circumstances allow. 167 The need for and timing of operative intervention in patients with severe ulceration or necrosis without clear evidence of perforation remains controversial. Comparative analyses are difficult in this patient population. Some authorities have suggested that early operative exploration decreases mortality 168,169 but others cite lower mortality rates and complete healing in patients with non-operative supportive care. 159 Advanced age, tracheobronchial injuries, extended resections, and emergent esophagectomy are negative predictors for survival in those undergoing early surgical management. 169 As such, management must be considered on an individualized basis. Inducing emesis or placing a nasogastric tube to clear or dilute the GI tract of the caustic agent is contraindicated because it may re-expose the esophagus, oropharynx, and airway to the caustic agent. Induced retching and vomiting may increase the risk of perforation. The use of neutralizing agents is not recommended because they have not been shown to be efficacious, may lead to increased thermal injury, and may also promote retching and emesis. 170 The routine use of glucocorticoids 156 and systemic antibiotics 154 is not recommended, but use of a PPI may reduce complications. 171 Late complications up to 1/3 of caustic ingestion patients will develop esophageal stricture after initial recovery, see Fig 28.13. Stricture formation presents most commonly at 2 months after injury but can occur at any time from 2 weeks to many years after the initial injury. 158 Stricture formation occurs more commonly following more severe, grade IIB or 3, injuries, see Table 28.1. The primary treatment of esophageal strictures secondary to caustic ingestion is frequent dilation. Endoscopic management of caustic strictures must be deliberate, with gradual and incremental progressive dilation to 15 mm or until symptom relief is obtained. 172 Endoscopic injection of triamcinolone into the stricture or use of topical mitomycin has been reported to be beneficial in treating caustic strictures. 173,174 The perforation rate is 0.5% for endoscopic dilation of chronic caustic strictures, and as many as 10% to 50% of patients will eventually require operative intervention. Those requiring surgical intervention for late complications have better functional outcome and survival than those requiring early surgery for the management of caustic ingestions. 169 Esophageal resection with an esophagogastric anastomosis, esophagojejunostomy, or colonic interposition may be considered. 175 Case reports have described successful treatment with the use of temporary esophageal stents soon after caustic ingestion, but there is insufficient evidence to support recommendations for routine prophylactic stenting or for prophylactic early endoscopic dilation to prevent caustic-related strictures. 170 Antral and pyloric strictures may also occur after caustic injury, Fig 28.16. Antral and pyloric stenoses will usually develop 1 to 6 weeks after caustic ingestion but can also occur years later. 154 The risk of antral stenosis is also related to the degree of injury. Endoscopic dilation with the addition of acid suppression is successful in many patients, but many others will require antrectomy. Alkaline caustic ingestion, in particular, is associated with an increased risk for squamous cell cancer of the esophagus. Patients with a history of lye ingestion have a 1,000-fold increased risk of developing esophageal cancer, with a lag time from injury of approximately 40 years. 176 Periodic endoscopic surveillance is advocated every 1 to 3 years, beginning 20 years after the caustic ingestion. Fig 28.17 summarizes the time course of complications from caustic ingestions reviewed in this section.